even no time to develop IgG antibodies from mother to, because IgG cross placenta, it can't reach the child because it takes IgG development takes some period, maybe 1 week, 2 weeks. So child is at a risk of, child acquired the virus, but no immune protection because child is, it's a neonate. So it takes some time to develop IgG in early stage. So they are at risk of neonatal varicella, not congenital on that case. So that in this case, we give intravenous immunoglobulins. About the diagnosis, it's almost clinical. Laboratory confirmation, we can do polymerase chain reaction assays. Direct detection, electron microscopy, then serology. Presence of varicella source immunoglobulin indicate past infection. IgM indicative reason, but it takes again 90 days life. So direct detection or PCR is or immunofluorescence is very much helpful. So prophylaxis varicella source immunoglobulin vitae, and it's a vaccine preventable condition. Live attenuated varicella vaccine is available. Preventive measures should be considered for individuals at risk of contracting severe varicella disease, like those who are having immunocompromised status, and also neonates, leukemic children, and pregnant. When urgent protection is needed, we go for passive immunization. So Zoster immunoglobulin is the preparation of choice, but it's expensive. It's usually not available, not frequently available. So always should be given, but always human immunoglobulin should be given, but we have to think, we have to wait. Herpes zoster, it's another disease entity. Zoster is the manifestation of recurrent infection following primary attack of chickenpox. Both chickenpox and herpes zoster shingles are caused by varicella. Unlike herpes labialis, repeated recurrence of zoster is rare. Zoster recurrences are very rare. Infection typically affect adults of middle age or over. So usually pain precedes the vesicle. Shingles cause severe pain, commonly occurs in dermatomal pattern like particular. Trigeminal nerve is affected in 15% cases of shingles. Lesion often localized in one side, but those who are immunocompromised, it can cause a generalized disseminated disease. Those who are having recent surgeries, having high stress, those who develop fever or kind of immunosuppressive therapy are more prone to develop shingles. Treatment is, in severe cases, we advise oral acyclovir, 800 mg 5 times daily for 7 to 10 days. It's the best method of therapy because it enhances the healing, and ultimately, because mind you, these vesicles are, if fluid is there, vesicles contain fluid, contact, then it leads to spreading of the disease to others. So one way it can be prevent infection as same as it reduce the crust and enhance the healing and relieve the symptoms. Ramsay-Hunt syndrome. Involvement facial nerve with varicella zoster virus leads to idiopathic facial nerve palsy. Basically, in external auditory meatus can observe when the patient present with facial nerve palsy. Always need to check about their clinical examination. So when vesicles can be seen, vesicles on palate, also one possibility. Symptoms: patient feel dizziness, loss of taste. It's often self-limiting. Sometimes it can cause permanent facial weakness. About gamma, beta, family of beta, herpes family, subfamily, double-stranded DNA virus, nucleocapsid, 100.0 nanometer in diameter, no need diameter, but it's double-stranded envelope virus, cytomegalovirus. It causes cytomegalo inclusion disease of newborn. It's a broad spectrum disease. viral infection and disease. It causes hepatomegaly, jaundice, thrombocytopenic purpura likewise, microcephaly, cerebral calcifications. Primary infection often asymptomatic. In a minority of cases, syndrome infection mononucleosis may develop. It's light, which consists of fever, lymphadenopathy, and splenomegaly. Immunocompromised patients such as transplant recipients and AIDS patients are more prone to develop cytomegalovirus severe form of disease such as pneumonitis, retinitis, colitis, and encephalopathy. Reactivation of reinfection is usually asymptomatic except in immunocompromised patients. Laboratory diagnosis. Clinical plus laboratory, we do urine, saliva, semen, and cervical secretions, neonate urine, we go for PCR we can do at the same time microscopy, centrifuge deposit of secretions. Once we do GM size scan, cytomegalic cells we can see. Apart from that, the histopathology, endo-GM size staining, we can see open and owl's eye appearance. So it is diagnostic. Prevention. No vaccine available. There are vaccines but still under development. For the patients with transplant recipients, CMV disease is prevented by screening and matching the CMV status of the donor and recipient. Always it's required. Use of CMV negative blood for transfusion, that's another one. So high costly procedures. Administration of CMV immunoglobulin to seronegative recipient prior to transplant, that's another way. Give antiviral agents such as acyclo and mainly ganciclo are prophylactic. Ganciclo is for CMV. About Epstein-Barr virus, which causes Burkitt lymphoma, it's an oncogenic virus. Affinity of B lymphocyte, CD21 receptor. Cluster of differentiation, CD means. 80 to 90% of children may be those who are affected are 3 years of age. Often asymptomatic, not highly contagious. Infectivity is less. Tendency to. Droplets are not infectious as varicella. So saliva or pharyngeal secretions. It causes infectious mononucleosis. Incubation period 4 to 8 weeks. It causes glandular disease or kissing disease. Acute self-limiting. Fever, sore throat is the main presentation. Lymphadenopathy there around the cervical area. Subclinical hepatitis may be there. Tendon splenomegaly also may be there. Sore throat, cervical lymphadenopathy, hepatitis, splenomegaly. Burkitt lymphoma. Endemically in parts of Africa, luckily. It occurs in children aged 3 to 14 years. Response favorable for chemotherapy. It's a lymphoma. Nasopharyngeal carcinoma, another one. Malignant tumor of the squamous epithelium of the nasopharynx caused by Epstein-Barr virus. Prevalent is southern China. And usually present in late and thus the prognosis is poor. Lab diagnosis. Clinical as well as blood smear examination, atypical lymphocytosis can be seen. Whole banal test, heterophilic antibody detection test, inactivated serum, 1% sheep RBC suspension, can see the agglutination. And more specifically, antibody tests are there, IgM and IgG, and PCR must be 2. Nowadays it's available. About HSV 6 and 7, it was isolated on recent times. Transmission to oral secretions as this. It is thought that 6 and 7 HSV, human herpes virus, are related to each other in a similar manner to HSV 1 and 2, simplex 1 and 2. Cause extanthema sabitum, roseola infantum. High fever with generalized rash is there. Chronic fatigue syndrome also associated. What HVY, herpes, human herpes A, originally isolated from cells of Kaposi sarcoma. So it's another virus which is oncogenic virus. Kaposi sarcoma mostly have antibodies again HHV, so it's proven. So treatment is often surgical resection and for the chemotherapy.